Good afternoon, everyone. My name is Morgan Reinig from the New England QIN-QIO, and I wanted to thank you for joining us for today's webinar for INTERACT on Part 1 of Communication Tools and the PDSA Cycle presented by Florence and Sheila Eckenrode. Before we get started, I want to review a few housekeeping items. This call is being recorded, and we'll provide you with instructions on accessing it at the end of the webinar. The phone lines are on mute for the duration of the program, and we will be taking questions at the end, and I will let you know how to unmute your line at that time. So for now, I'll pass it over to Sheila to get the program rolling.
Good afternoon, INTERACT partners. We're glad you're here, and welcome to Session 4 in our INTERACT webinar series. Today we're going to be discussing two communication tools, the SBAR and the Stop and Watch SBAR, meaning Situation, Background, Assessment, and Recommendation Tool. And I'll spend some time going over the PDSA, or Plan, Do, Study, Act cycle, and how that process can be used to help you implement both Stop and Watch and SBAR. So today's session objectives include understanding the Plan, Do, Study, Act, or PDSA cycle, understanding how to use the Stop and Watch tool, understand how to use the Situation, Background, Assessment, Recommendation tool, or SBAR tool, to improve communication between caregivers, to develop a plan of implementation for those two new tools, and then, of course, at the end, we'll have our 15-minute state-specific group discussion. We'd like to remind you who we are all the time. I guess we're afraid that you'll forget. From Connecticut, it's Florence Johnson, myself, Sheila Eckenrode, Carol Dietz. Rhode Island, Kathleen Calandra, Nelia Odom. New Hampshire, Joyce Johnson, Margaret Crowley. Vermont, Liz Kleppner, Gail Harbour. Massachusetts, Lynn Chase, Cheryl Leary, and Lori Nervone. And Maine, Maureen Berry. And we are the New England QIN-QIO Care Transition Team. Okay. As we go through these webinars, we tell you about these tools and trust that you're going to be able to go through it and implement them, but we need to do a bit of a check now and then to see if that's actually happening. So I have a polling question. Last month, if you remember, we went over the quality improvement tool and the root cause analysis process, and we'd like to know whether or not you have implemented this tool and you were able to use it at least once in the last month or so. So, take a minute to answer that question. Please answer honestly. Oh, and after you answer yes or no, Morgan just reminded me you have to hit the submit button or your vote won't be counted. So thank you for taking a few seconds to do that. Okay, so we're getting there. It looks like 24 people have been able to perform a root cause analysis using the quality improvement tool, and I congratulate you and hope that the folks that haven't had an opportunity to do that yet will have that opportunity in the next month or so. So thank you very much for participating in that poll, and I'm going to turn it over. Technical difficulties, sorry. I'm hoping to turn this over to Florence. Oh, I'm sorry. We've got another question for you. My mistake. Since the last webinar, have you been able to use the INTERACT medication reconciliation tool at least once? If you recall, that was another tool that Florence had reviewed last month. So another poll, if you could take a second to answer that, I would appreciate it. Waiting for those results. Okay, this seems to be a less popular tool than the quality improvement tool. Maybe we can get some feedback from the participants about that at the end of this session when we have our 15-minute huddle. All right, now I will turn you over to Florence Johnson, who will describe both the SBAR and Stop and Watch communication tools.
Good afternoon, everyone. Thank you for joining us again. So today's focus is looking at internal communication tools and focusing mainly on the SBAR tool for nursing and the Stop and Watch for ancillary staff. The Stop and Watch is an early warning tool. It's a nursing communication tool, so you have ancillary staff feeding information to the nurse to help to catch early signs of a person decompensating. It communicates the changing condition early, and it's an efficient way of bringing together all pertinent information. INTERACT recognizes that nurses are busy administering medication, talking to physicians, taking doctor's orders, admitting new patients and new residents, So CNAs can be busy providing direct care. Stop and Watch is a tool that can help close the communication gap. It has been revised over the last couple of years to be more succinct to what is happening within the facility. And I guess after reviewing the use for a while, they realized that the users were requesting to have a section on the tool that recognizes that there was no change in a resident. So if you have someone that you initiated this discussion or this early warning tool on, and then you're watching them for the next 72 hours, and there were no changes, you can just check off the box that says no changes. Again, the Stop and Watch tool is an early warning tool that initially was designed to be used by CNAs. But later on, we find out that it's actually appropriate for everyone to use. Nurses need to be educated on what they should do upon receiving one of these documents. They need to acknowledge the fact that they received it. They need to act upon it and follow up on the information that's being given to them. Your facilities need to have a process in place for ordering the tool and restocking when you run out. I hope that you can see this. This is a screenshot of what the Stop and Watch tool looks like. It's NCR, so it's carbon copied. You have the top copy that goes to the nurse, and the carbon copy stays with the CNA or the person that's initiating the communication. So Stop and Watch stands for S means seems to be different than usual. T stands for talks or communicates less. The O stands for overall needs more help. The P stands for pain. It could be a new pain. It could be a worsening pain. Anything that makes the resident participate less in their activities of daily living. A stands for 8 less. N stands for no bowel movement in the last 3 days or diarrhea. The D stands for drink less. W is weight change. A is agitated or nervous more than usual. T is tired, weak, confused, or drowsy. C is the change in skin color or condition. And H is help with walking, transferring, toileting more than usual. And then you see that little box underneath all that that says, check here if no change noted. And then it has you put in the resident's name, the person that's reporting it, who it was reported to, what time, and the date, and then the nurse that's responding to it and when they responded. I'm going to make some suggestions on how you should roll this out. This is a great tool. It helps the CNAs and other ancillary staff in your building to feel empowered. It makes them feel as part of the care team. I would recommend that you select one unit, especially if you're a big facility. Meet with the staff, get some input on the logistics of how you should roll this out and where they should store the information. Nothing worse than implementing something and not having it work because those that need to be engaged were not engaged early on in the process. You can have this. You can order this form either on INTERACT.net, or you can have your provider, your vendor, whomever you order your paper goods from, can also print this up for you. I would recommend making a laminated copy that you place in a prominent place within your facility so that aides and your ancillary staff know it's there. Trial it for a week, then meet with your staff to discuss how it was used, any barriers, and any suggestions from them on how it could be improved. Identify staff that may need additional training and then offer that training. Then go back, try it for another week, and continue to monitor. So, of course, loving polling questions, I have another polling question for you. Have you implemented the Stop and Watch tool in your facility? And while you are entering your responses, I'm just going to offer you ways to spread the use of Stop and Watch once you've implemented it. So once the process has been piloted on a unit and it's been monitored, reviewed, and improved upon, begin to spread it to other units, and all the staff would direct resident care contact with direct resident contact on a daily basis. Roll it on to other units. You will conduct the education and the training as you did with the unit that was piloted on. Use your CNAs and your nurses who excelled to be role models and to help mentor other units. Involve and train your family members, and then monitor and identify areas for enhancement. And as Sheila will talk to you about, do your PDSA cycles for improvement. All right, still waiting for results. Oh, sorry. Oh, great. So a lot of you are using it already. This is awesome. So those that are not, hopefully when we ask this question next month, we will get a higher response rate. Thank you so much for taking the time to do that. So who's your target audience for the Stop and Watch? We have your CNAs, any other nursing staff, or anyone that is an adjunct to nursing, rehab therapists, your dietary staff, housekeeping activities, so basically anyone who has direct resident contact on a daily basis. Also, family and close friends. We say family and close friends because they spend as much time with your residents either in the facility or they take them out on outings. Actually, one of our facilities here noted that they use them when they send the residents out with their family because you never know what's going to happen while they're out, and then by the time the family gets them back to you, they've totally forgotten that, she hadn't had a bowel movement, she was home with us for a week, and she didn't have a bowel movement. So it's important to make sure that anyone at all that has contact with your resident is included in this training, even your receptionist, because a lot of times the residents go out and they sit out in the public area. So I would not count anybody out. Methods for using this should be used to report any subtle changes during the shift, during routine care. So if a CNA is given a bath and they notice something, after they're done with the bath, they should note it and then share that with the nurse. Once this has been generated, it should become part of your 24-hour reporting system. Should be discussed at morning meetings, and feedback should be given to the person who initiated this communication. That's very important to help people feel a part of and to feel that they were heard. If we don't offer that feedback, that kind of breaks the chain in the circle. So here are some barriers to the successful rolling out of the Stop and Watch. Inconsistent assignment. It's important that people know their resident. That's when you learn to catch nuances early on. Staff turnover at the frontline level, and also leadership turnover can affect how well these are implemented. Broken relationships and broken communication between nurse and CNA, CNA to CNA. Resistance to change in verbal method of communication or notification. If you're using this by itself without actually implementing the whole INTERACT program, and that's why we're having this training, to make sure that the whole program is implemented and not just bits and pieces of it. And then, of course, lack of leadership support. It's important that you keep the tool where it's easily accessible by the staff that will use it. It does no good to have it locked up in the administrator's office and then someone uses the last copy on a Friday and there's none available till someone comes back in on Monday to restock. It's important to translate things into necessary languages, so we shouldn't be using a lot of technical terms that maybe a CNA or a family member would not understand. It's important that we teach, we follow up, we monitor, we role model, and mentor the things that we are asking our people to do. And even having some teach back to make sure that what you think you said is what is heard. And I cannot highlight this enough, that consistent assignment is crucial to the success of this. And as you use this, you will notice an improved culture and communication patterns in your facility. You should try to work this along with improving. This will help you to improve your shift-to-shift report process, and it will also be helpful if you're having huddles. All right. I think I said quite a bit about the Stop and Watch tool, so we will now move on to the SBAR tool. Now, Sheila told you what SBAR stood for: situation, background, assessment, and recommendation. This tool was initially developed in the military during war times when people did not have 45 minutes to report off. It's a quick, succinct way of communicating with your medical providers. It's a nursing communication tool. It communicates changes in condition, and it's a means to efficiently bring together all pertinent information. The one great thing that the SBAR does for you is that to complete it before you call the doctor, it will have all the information that you need, so you're not running around trying to find a chart or gather different binders as you're talking to the physician. The purpose of the SBAR tool is to improve communication. It's a consistent language, so if Nurse Sheila is filling it out or Nurse Florence is filling it out, the language will essentially be the same. It's a standardized criteria. It has clear guidelines, and the communication is efficient and effective. The SBAR tool is to be used with any change in condition. It can be used as a standard shift charting. And if you notice a change in condition, it should be used for the next 72 hours to assess that change in condition. It can be used when there's a new order or a change in the plan of care. It improves communication, like I said before, with the change of shift report when a nurse is reporting to the physician or the nurse practitioner, especially if that person is coming in to see your resident. You can have this document that completely gives a full picture of what happened and why you're requesting them to come in to assess the resident. It can also be used across settings as a warm handoff. So if you're sending a resident to the emergency room, this gives them a full picture of what's going on. And if you're transferring to the emergency room, you should be including a copy of the SBAR tool with the transfer. Now, including the SBAR does not mean that you forego the warm handoff. It's still important that you call the emergency room to let them know that you're sending somebody. All right, so I put some screenshots, and I hope that you can see it. The SBAR tool is about a 4-page document. Don't fret, most of it is check boxes. There are a few items that you have to put in, say, for instance, your vital signs, demographics on the resident. So the situation, which is page 1, basically says, what is making you fill out this form? So you tell what the change of condition is or the symptom that you're recognizing. When did it start? So it gives you really, really full details. What made it get worse? What made it get better? Is this a condition that you've seen before? And then the background talks about describing the resident. Is this person a long-term stay person? Is it a post-acute care? Medication alert, were there any changes in their meds in the past week or so? It talks about if they're diabetic, any changes in their insulin or their blood sugars, and then looking at vital signs, what did you get? And then page 2 continues to look at the resident evaluation, their mental status, their functional status, if there's any behavioral evaluation that was completed, It looks at their respiratory status and just goes through the whole system, cardiovascular, GI and abdomen. Page 3 continues on with the urinary system, the skin, if there's any pain, neurological issues, and then it looks at advanced care planning in case you have to transfer the resident. Page 4 has you summarizing your observation and your evaluation, and the review and notify. So it asks you what primary care clinician did you contact, when did you contact them, and recommendations of the clinician. And then there's some check boxes about any testing that was done, x-rays, blood tests, urine cultures or EKG, and then interventions. Did you have to start an IV? Did you increase their fluids? Did you have to put them on oxygen? And then there's a section where you can actually write out additional information that you think is pertinent. And there's a section here for when the family was notified, and then the signature of the person that completed this form. Some EHRs have the SBAR embedded within the program. It's important that you find out with your particular EHR how to print down the copy once it's completed. So the takeaways from this section is that it's important to educate all your staff as well as your providers. I was actually on a webinar about this time last year where a physician was presenting on, and he talked about getting a phone call from a nurse from a skilled nursing facility, and he said he could tell by the way she was reporting off that she had not used the SBAR tool, and he stopped her. He said, "Did you complete the SBAR?" She said no. He said to her, "Well, hang up now, complete the SBAR tool, and when you've done that, you can call me back and give me a report." I would love for Connecticut to get to that point where physicians are actually looking to hear that people are using this tool as a means of communication. And once you've implemented the SBAR tool, please remove any old progress notes that you have in the facility, because in making site visits to our facilities around Connecticut, that's one of the biggest barriers that people have with implementing anything new, is that we want to hold on to everything. So when you bring something in, you need to take something out. It's confusing to staff if there's still old documents within the building, because then it feels as if they have a choice on which tool to use. We don't want to have choices. We want to standardize, and we want everyone using the SBAR tool. Once the SBAR, if you're using the SBAR as a paper tool, it becomes part of the resident's medical records. It's now part of your progress note. And just like anything else, you only complete the SBAR when you have a change in condition. We don't chart on people on a daily basis anyway. So yes, it's a 4-page document, but you only need it when there's a change in condition. And you know me, I have one more polling question. Have you implemented the SBAR tool in your facility? And please don't forget to hit the submit button when you've entered your response. Right, the poll has ended. Give us a few seconds to get the calculation. Oh, wow. That is awesome. I am so impressed to have one of you guys teaching the course. All right, thank you so much. I will now give the floor back to Sheila.
Thank you, Florence. I'd like to talk to you a little bit about PDSA cycles or Plan, Do, Study, Act cycles. You might have heard them called PDCA cycles. This is a process that we use a lot in healthcare quality improvement, and we use it in other industries. We use it in our personal lives, sometimes not even realizing that it's what we're doing. But basically, these are small cycles of change or tests of change. So the plan part is just planning what you're going to do, try the intervention, study, see if it's working, and act. So let me walk you through this a little bit because it's worth our time to just reflect on this. If you use this in your clinical practice, or if you have used it, maybe you would like to dust it off and try it again, this is a good time when you're implementing something new. So plan, basically you have a hypothesis, and this woman is saying, we can implement stop and watch on our West unit. That's what she's thinking. You see her thinking that big thing is over her head. From that, we're going to move to the do. So how are we going to do that? Well, in this hypothetical situation, staff development will present the stop and watch, and pads will be kept in the nurse's station. It's a great time to brainstorm with your staff. You know, you want to just get some ideas out there. How can we do this? How can we get this ball rolling? So these are the ideas that the staff of West unit have generated. The charge nurse will ask CNAs if they have any stop and watch slips at the end of the shift. Shift supervisor will collect them when she does her rounds. Any stop and watch slips that were filled out will be brought to morning report. The shift supervisor will report suggested plan back to the unit nurse and CNA, which auto-corrected to CAN, sorry about that. And stop and watch slips will be shared with the APRN MD that comes to evaluate the resident. Any other ideas your staff might have. So that's the do part. So how do we know if this is working? And this has always been a frustration to me. When I worked in middle management and I would try to implement something new, in my young and naive days, the way I would try to assess the success of that implementation was to ask the staff how it's going. And invariably, there would be a couple of people who would say, this is going great, I'm so glad we're doing this. There'd be another couple of people who would say, this is the most boneheaded idea you've come up with yet. And then there would be the third group who would say, what are you talking about? I didn't hear about this implementation. I didn't hear about this plan at all. So one of the reasons that we use PDSA cycles is because we can put some rigor into the assessment of whether or not something's been implemented or a problem has been solved or something's working. So in the case of our stop and watch implementation, we might look at the number of stop and watch slips turned in. You'd expect it, you're starting with 0 if it's a new process. So you'd expect them to increase steadily as the process becomes ingrained in the culture of the unit. The number of stop and watch slips that result in a change of resident care plan might tell you how effective they are. You're using these to detect subtle changes in resident condition, so you would expect that these slips would eventually result in some sort of change in the resident care plan. Staff feedback and some outcome measures, unplanned readmissions, emergency department visits. So these are the things we could study. We could assess the effectiveness of the implementation of stop and watch by doing some of these metrics. And the act part is just the end of the cycle where we assess what worked and maybe tweak it. So In this hypothetical situation, the CNAs request stop and watch pads they can carry in their pockets because they can't run back to the nurse's station and find them and disrupt their workflow to fill them out. Maybe stop and watch slips should be made available to MDs and APRNs for routine rounds. So when a doc comes to see her patient, you can give her the stop and watch slips that might have been filled out in the preceding few weeks. Fill in some of the gaps and get a better picture of the patient. And then if it seems to be working, consider rolling out to others. So this just starts that cycle all over again. So think about, we've decided to implement the stop and watch pads being carried in CNA's pockets. So you might do a sort of informal walkthrough and tap CNAs on the shoulder after a week or two and say, hey, do you have that stop and watch pad in your pocket? How's that working out for you? And if most of them don't, maybe they could say that's not working the way it is. So we're just constantly adjusting the plan, tweaking it to make it more effective. We test something, we decide whether or not we think it passed the test or failed it, and we adjust it. And this is a really good way to implement new processes, as well as a good way to solve problems. And it's, again, as I said, we use it a lot in healthcare quality improvement. You're probably using it at home and in your personal life. It's used in other industries, and it's effective. So when applying PDSA, we want to ask ourselves 3 questions. What do we want to do? What can we do to make that happen? What changes can we make that will result in an improvement? And how do we know that a change is an improvement? How will we measure whether or not this is actually working? And as I said, it's used everywhere. Here's a 4th grade class right here in Connecticut that decided that silent reading time is too noisy, and some of the things they were going to do, say please be quiet, don't chat, and then you can see how they were going to study it by tallying up how many times they had to do these interventions, thinking that maybe if they do them over and over again, somehow being quiet during silent reading would become ingrained in that class. So I'm rooting for them. I hope that works out. Okay. So that's PDSA in a summary. This is the part of the call where we invite the other states to jump off and our Connecticut nursing homes to stay on the line. Oh, sure. But before we do that, Florence suggested, and I think this is a good suggestion, to see if there's any questions in the audience at large that you'd like to have answered by Florence and I. And
go ahead, if you have a question, press *6 on your phone to unmute your line.
Hi, I'm Ariana Miner. I'm the new DNS here at Norway Center in Maine. I have a quick question about the SBAR form.
Sure.
In facilities I've worked in the past, there's always been conflict. Does the SBAR count as a nurse's note?
Yes, it does.
Okay, so like if, it was, for a changing condition, that would count as your first nurse's note?
Correct.
Okay.
And then once you initiate it, then everyone else that writes on that condition should use the SBAR tool for the next 72 hours till it's resolved.
Okay, so not just a general note, it needs to be on the SBAR form for the next 72 hours?
Correct.
So a new form, okay. Okay, thank you so much.
You're welcome.
This is Sheila. I'm just going to jump in with my 2 cents, even though I wasn't asked. I think it's so important to replace any existing documentation with SBAR, because the last thing you want to ask people to do is document the same thing in 2 places. You know there's going to be differences, and it's going to become a medical legal problem. So for every form you give people, take 1 away. If you could take 2 away, all the better. Any other questions for the region?
If we have no more questions, I just want to give you guys a few more details before you jump off onto your state calls. When you close out of this webinar, When you close out of this webinar, the evaluation for today's webinar will immediately pop up on your computer. If you could please fill that out, we would greatly appreciate it. If you don't have time to fill it out right now, or you're sharing your computer with somebody else, you will receive an email tomorrow morning with the link to the evaluation, as well as the link to the event page on our website. The PowerPoint presentation from today is already posted on the website you will receive, but within a few business days, the recording of today's webinar and the transcript will also be added. Please make sure to mark your calendars for our next Interact webinar on June 24th from 1 to 2, covering Communication Tools Part 2 and Process Mapping. I'll give it back to Sheila for the last little detail.
Thank you, Morgan. So now I should have my Connecticut folks on the line with us, and we can talk about some state-specific things.
Those in New Hampshire, Joyce is unavailable today, so you will not be having your 15-minute call today. But you can get in contact with her if you have any questions.
Excellent. Okay, we're going to take a few minutes to talk about last month's homework. Okay. Florence just pointed out I have to give you a second to get your breath here and sort ourselves out. Okay, so if we can talk a little bit amongst ourselves about issues that might have arisen from last month's homework. If you have some stories to share, I would love to hear about people who have successfully implemented Stop and Watch in their facilities and how that's working. And it would also be great to share a root cause analysis experience if you're up for that. Before we jump into that, though, I do want to talk about Interact participation and how we're going to honor and recognize the people who've taken this journey with us. So we plan to issue an Interact participation certificate at the end of this webinar series, and that will be presented to anyone who's participated in 75% of the webinars, that's at least 7 webinars, and sent monthly readmission data to Qualidigm for at least 3 months. Or enter the data into Advancing Excellence Tool, Safely Reducing Hospitalization Tracking Tool, so that's a mouthful, and sign the data use agreement. If you recall, a couple of months ago, Florence had talked about how you can use the Advancing Excellence Tool and sign a data use agreement with us, and then you won't have to be bothered sending us the data monthly. We can just go in and fetch it ourselves. So it's one less thing to ask busy nursing home staff to do. If you can't attend all the webinars, the monthly webinars, or if you haven't attended them all, you can access these webinars by going to the New England QIN-QIO website. The link is right there. Clicking on the Events tab, scrolling down to Previous Events link, and click on the webinar recording link. You'll be asked to register and just put in your name and your facility name, and that way we can make sure you're credited with attendance. Okay. Speaking of data and entering data, we're hoping that everyone's set up to do this, but fully realize that this is not an easy process to implement. You have to assign someone to do it. You have to figure out how to do it. So we wanted to see how these seeds are taking root out there. So if you can take a minute to let us know if you've been inputting data and where you've been putting it, either Advancing Excellence, using the Interact Readmission Tracking Tool, a paper tool, maybe a facility or corporate-based tool for tracking readmissions, or you haven't started tracking readmissions at all. So this is an anonymous call. Be honest. If you're not doing it, tell the truth and shame the devil, like the nuns used to tell us. And this will help us get a pulse on how it's going for people in terms of tracking readmissions, so we can reach out to people who might be struggling with getting this up and going. So take a second to fill that out. Oh, next one.
This is Shannon from Southington Care. I have a quick question for you. We're doing the log here on our computer, but I have not been able to figure out how to share that information back.
So are you asking about how to submit it to Advance and Excellence?
Yeah, I would do either one. I actually kind of like the one where you can just come and get the information yourself.
And that would be you submitting it to Advance and Excellence. So Shannon, I will email you the instructions on how to do that.
Okay, great. Thank you.
You're welcome.
Okay. The poll is open. We might have to give them a few extra seconds. Did we lose some time there, Morgan? Okay, can we do it again?
Hey, Jennifer, this is Morgan. Is there any way we can open that polling question again?
Sure.
Thank you.
Okay. Thank you for the polling question. And thank you for your patience in taking the time to do this, because this is important, that we all know how easy or how difficult this is to get done. So if you could take a second to answer that question, we'll know where the data is kept at the moment and how to look for it.
And since Shannon asked a question about how to submit data, I think I'll just email everybody so that everyone has the direction on how to submit.
Okay, that poll is ended. Great. So we're working on it. Again, please don't hesitate to reach out to any member of the Connecticut team here. Florence is going to be going on tour to the various community meetings, and if you attend them, she'll be meeting or available to meet with nursing home staff prior to or after the regularly scheduled community meeting to go over this very thing, readmission tracking and the use of the tool. And just reach out to any of us, because we appreciate how difficult this is, and it's a commitment of time and it's a responsibility that has to be assigned. But it's so important, because we'll never know whether or not we're getting better or getting worse or staying the same without that information. So thank you so much for all you've done. Okay. Moving along. There we go. All right. So just to go over what happened last month, we went over the root cause analysis tool, the quality improvement tool, and we asked that you download them, take a look at them with your team, hopefully come up with a plan on how to implement them, and maybe get them going at least one unit. We also talked about the medication reconciliation tool. I saw in the poll that tool really didn't seem to strike people's fancy, that not many people sought to implement that. And I'll be interested to hear from people what they thought of that. We talked about developing a timeline last month of how long you'll sort of allow yourself to get this going. And then, again, having your team look at whatever data you were managed to collect and talk about what any problems you might have had collecting that data. So, I'd love to hear from folks about what it was like, what you were able to implement, any barriers, stumbling blocks, success stories, funny stories, bad stories.
It could be related to any of the tools.
Any of the tools, right, that we talked about. How about the folks that have implemented Stop and Watch? Does anybody want to share what that was like in your facility?
It's just you and I here, Sheila.
Hi, this is Dawn, the DNS in Milford.
Hi, Dawn.
Hi. So one of the things that I found here in my building is the lack of knowledge when filling out the SBAR and how important the information is for a successful report as well as transfer to the hospital. So I actually talked to my medical director and asked him to come in and present the importance of this, what it means to them, getting the information. So he's going to come in and speak with, all of the supervisors, all of the licensed staff, and, really inform them on, the readmissions and what it does as far as payment source. And it was supposed to be today, but he had to cancel, so it's next Wednesday.
And what facility is this? That's right, Dawn. That's great.
Yeah.
Good idea.
Just as a physician standpoint, how important that information is in getting to them, and how they're going to treat the person when they receive them.
Yeah, that's a great person to have in your corner, huh?
Yeah. Yep.
Anybody else have experiences with SBAR or how it's received? Or have you ever received information in SBAR format from another provider? I know that now in nursing schools and medical schools, SBAR is being taught as a standard form of communication. We're going to speak that language going forward, and you'll hear it more and more, which is a good thing because it's effective and it's a nice way to receive information. It helps to prioritize the important things, the presenting symptoms, the actual problem, while knowing what the background is and having an idea of what the initial plan from the nursing home would be.
It's a great tool when you have fresh new nurses. It helps them to really guide the communication that they will have with providers. It helps them to frame the information in a good and efficient way.
Mm-hmm. Right. There's nothing more awkward than when you're a new nurse than having that doctor APRN ask you the one question you don't have the answer to.
Well, I have a question for the general population on the line here. Are these trainings meeting your needs? Is there anything that you want from us that we're not giving you? Share freely so we can improve. We also have to do our PDSA cycles.
This is Shannon again from Southington. A couple of the problems that we're having is we'll fill out the SBAR, and if it's not something that's an emergency, we'll fax it over to the doctors. But because the SBAR is so cumbersome, it's many pages, the doctors get frustrated and don't want to read through it. And it would be nice if it only printed the part that you filled out, so the assessment portions of it that were pertinent to what you were doing. So if you left something like change in medication blank because that wasn't what you were assessing at the time, or that didn't need assessment, if that did not appear on the summary, it'd be a lot easier for the doctors to read through it and know exactly what was going on. Right now, they have to read through each section to figure out what's going on with the resident.
So when you print it out, are you able to just send to the physician the pertinent part, but then have the rest of it in the chart so that if they need to come in to see the person, they have the rest of the document, but you can send over just the assessment with the resident's name and demographics on it?
No, we have to send the entire SBAR, and that's the problem. They have to read through the entire SBAR, which doesn't have, sometimes it doesn't have pertinent information. Now the new one is 4 pages long, and now the doctor has to go through and find the X's for what's pertinent.
Mm-hmm. I can see how that would be a source of frustration.
Yeah, it would make much more sense as if when you click on it, that's the only thing that shows up.
Oh, you're sending them electronically or you're faxing them? Oh, I see. You're filling them out.
We're faxing it. And then what we've done now just recently is, because we went on to electronic medical records, we've made a template in our electronic medical records that, again, we can't do the same. It sends the entire 4 pages.
Oh, I see.
But especially if you're using it for a nursing note, too, because, like, if you were talking about using it either for 72 hours or on a daily basis for your nursing note as a template, you don't want to have to sift through 4 pages, 3 shifts, every single day to find out what's going on with the resident.
Right.
You want it just to contain the information, more concise and consolidated of what you addressed.
Let me think about that. Maybe we'll
feedback, and I can get that to the INTERACT team to see, and I'm sure they probably heard this, but I will get it to them and see what they give back.
Florence has friends in 5 places in the INTERACT world.
Any other comments? That's very useful. Thank you, Shannon.
Anything else? Hello? Okay.
Oh, okay. Hi, this is Linda from Elam Park. I guess I just wanted to say we had started using the SBAR, and as we, more than a year ago, and as we used it, we were able to eliminate the use of the traditional W-10. So it was one of those advantages of not having to rewrite for, saving some nursing time, especially when you are sending somebody out and of the essence. So we've been able to use that in addition to other documents from our EHR as interagency communication.
Oh, thank you for testifying.
You are a rock star.
That's how it's supposed to work.
You go. We're hoping someday we'll have a big W-10 bonfire.
Yeah, we got rid of them, The other thing we did with the Stop and Watch, as a CCRC, we introduced it across the campus and at employee meetings and actually at med staff and the board meeting. And we have received 2, one from our assisted living, our apartment area, and then we have received one. That was a housekeeper, and then we did receive one from a therapist who was somebody, so.
That is awesome. That's awesome.
Not too many.
Especially housekeeping, because they're always in those rooms, and they see a lot. They spend probably more time in the room, your patient, than any other discipline. Okay, I don't want to run over, so just very quickly.
Real quick, it's Shannon again. I talked to Barbara Cass just the other day, and I did get 2 emails back from her about the W-10. And she's going to send out a blast fax to everyone. She did verify that the W-10 we do not need to use if the information that we're sending off to the hospital through our electronic medical records contains all the same information.
Hooray, hooray. You know people in big places.
You've accomplished something that the rest of the state has been trying to do for 4 years.
It's nice to be
with joy. You go, girl.
I can't wait to get that blast back. I think I'm going to frame it and bring it to every emergency.
And I did get it from the state and from, DDS also. I got 2, both of them confirmed it.
That is awesome. Can you forward those emails to us?
How much is it worth to you?
Right, well, let's see, dinner?
We'll let you get on to the next training next month.
Okay, I will forward it to, who should I forward it to?
Florence or Sheila.
Okay.
Do you have her email?
So we have it on Interact?
Yes.
I'll just hop on to Interact. Okay.
Oh, thank you so much.
Thank you.
Fabulous news. All right, well, thank you. I don't want to keep people, so of course the reward for good work is always more of it. So here's homework for next time. Try to download the Stop and Watch and the SBAR tool if you're not using them already. Bring them to your Interact team, show them around, top them up, show them in any venue you have, staff meetings, medical director meetings. Come up with a plan of how you can implement at least one of these in the next month. And, think about the PDSA cycle. Think about how you'll measure whether or not the implementation is actually taking place. Give yourself some sort of timeline for implementation. And, again, debrief and see how it's going. That's the S&A part. Okay. This is a lot of homework. It looks like a lot more than this. Just take those tools, show them around, talk to your staff about how to get going with them. That's really what this is about. Wow, this is intimidating. Let's just move on. All right, thank you so much. And we'll talk again next month. And thanks so much for the great news about the W-10. All right.
Have a great afternoon, everyone.
Enjoy.